Today's talk will review primary topography-guided LASIK. We have no financial interest to disclose. The Alcon topography-guided software uses anterior corneal higher-order Zernike coefficients from the high-resolution Placido scan to generate an eye-specific HOA ablation map. This is then used by the laser to remove small amounts of corneal tissue within the traditional spherocylindrical ablation. Here's an example of the Contura treatment screen. In addition to anterior corneal HOAs, Contura also measures the anterior corneal astigmatism. The measured astigmatism can be surgeon modified, allowing treatment of any magnitude or axis of astigmatism that is desired. That's seen here on the modified line. By entering 0, 0, 0 in the modified fields, we obtain the HOA ablation map. This corneal HOA ablation treatment graphically represents the shapes, locations, and depths of the excimer laser tissue removal patterns that are delivered onto the cornea to correct the anterior corneal surface HOA. Topo-guided has advantages in virgin eyes, and not only with therapeutic cases where irregular corneas are fixed. It has been shown to be quite effective at improving subjective symptoms related to irregular corneal optics and increasing UDVA post-op. Now, corneal irregularities, asymmetries, occur in up to 40% of so-called normal corneas. These eyes have naturally occurring irregular astigmatism shown here. All of these corneas have normal keratoconus risk scores, and many are good candidates for laser vision correction. These asymmetric pre-op corneal topographies can develop into quality of vision issues post-LASIK. This is due to a uniform central ablation worsening these pre-op irregularities, increasing HOAs, particularly coma, leading to quality of vision symptoms. Primary topography-guided can help prevent these issues. Here we see pre-op irregularities becoming more accentuated after a traditional ablation. Notice from 1 diopters to 2.5 diopters of inferior steepening post-op. This is not ectasia and not a decentration, but rather worsening of pre-existing vertical asymmetry inducing vertical coma, causing patient quality of vision symptoms. Here's an example of superior steepening, this time treated with topo-guided. In the middle is the HOA ablation map, and then we see here the post-op cornea that is more regular, going from 1.5 to 0 diopters of superior steepening. Had this been treated conventionally, it could have accentuated the irregularity, leading to coma and symptoms. Here is another Contura case in a virgin cornea showing improved irregularity and less inferior steepening post-op. The TCAT FDA study in virgin eyes showed outstanding outcomes with almost 70% of eyes having 20/16 vision or better. These eyes were treated on the manifest refraction. As well, there was an actual decrease in night vision disturbances as compared to pre-op eyes, in keeping with the decrease in HOAs. At first I thought, are the results too good to be true? Let's dig a bit deeper. The FDA study was limited to symmetrical normal corneas, excluding eyes with naturally occurring irregular corneal astigmatism. Only eyes with a small difference between refractive astigmatism and anterior corneal topoastigmatism in both magnitude and axis were included. These are very tight criteria. The discrepancy between the two is referred to as ocular residual astigmatism, or ORA. Therefore, all eyes with larger magnitude and axis discrepancies were excluded. ORA is the most objective parameter to assess the difference between subjective manifest refractive astigmatism, RA, and topography measured anterior corneal astigmatism, ACA. It can be due to large magnitude or axis discrepancy, or a combination of both. Low ORA occurs when RA is similar to ACA. Various properties in optics of the eye are thought to contribute to ORA, including the anterior corneal HOA, posterior cornea, the lens, and the brain. So what percentage of eyes were excluded in the FDA study? Looking at 64,000 eyes, we calculated that only 34% of all corneas would have been included within the FDA criteria, so 66% were excluded due to aura. So were the results so good because of TCAT technology or because they started with uniform symmetrical corneas with low aura? No other published LASIK study was done on pre-selected corneas removing eyes with any non-orthogonal sill or discrepancy between RA and ACA. This was a first. Can we obtain similar outcomes without FDA exclusion criteria? Before answering, let's look at what is thought to influence topo-guided outcomes. One theory is that pre-op corneal coma is thought to affect the subjective refractive cylinder, and therefore treating the full manifest may induce new cylinder. Treating and removing anterior corneal HOAs might result in post-op surprises when treating the full manifest refractive cylinder, and the asymmetric nature of the HOA ablation on the cornea, especially if deep, may induce a refractive effect. However, these assumptions come from observations stemming from highly aberrated corneas with pathology. Does this hold true in primary healthy eyes with a much lower range of aberrations? Other factors that can affect outcomes: poor image acquisition or wrong refraction will use wrong data to treat. This is one of the most important factors. Treatment-induced corneal epithelial changes might be less predictable than symmetrical ablations. And finally, aura is also thought to affect outcomes. We will examine and explore why some surgeons believe that higher aura eyes should be excluded from topo-guided treatments and whether this is true or not. So what are the treatment controversies? Can we obtain excellent outcomes without the strict FDA exclusion criteria? Do we treat the manifest or corneal astigmatism magnitude and axis? Do anterior corneal HOA and coma impact subjective manifest refraction or aura in normal, healthy virgin eyes? Should high aura or high HOA ablation depth eyes be excluded? Do normal healthy eyes behave the same way as eyes that acquire HOA coma through injury or pathology and then need therapeutic treatment? What do we treat when RA and ACA disagree? Subjective manifest refractive astigmatism or contura topo measured anterior corneal astigmatism like with LIRA and TMR? Do we go in between or partial such as vector planning or hybrid, or do we use a commercial software such as Forcities? Or just don't use topo-guided? Would we use traditional ablation instead? Here you see a large axis discrepancy of 90 degrees between RA and ACA in both eyes. Alcon exclusion criteria for treatment say that greater than 2 diopters, the axis should not differ more than 5 degrees from topo axis. For subjective cylinder less than 1.75 diopters, the axis should not differ more than 10 degrees, and the subjective cylinder should not differ more than 1.25 diopters in magnitude, previously 0.75 diopters, when compared to topo. If the above criteria are not met, then you plan away for an optimized or Q-value adjusted treatment. Alcon guidelines on how to treat: if subjective cylinder is greater than calculated cylinder, then you treat on the contura measured cylinder and axis with an adjustment so that the treatment spherical equivalent and subjective spherical equivalent are equal. And if the subjective cylinder is less than the calculated cylinder, you treat in the midpoint between the two, and you treat on the contura measured axis. Who in the audience follows these recommendations? I treat differently, and I will show you why. The recommendation to treat on ACA is based on a potential benefit of a more uniform and symmetrical corneal shape, and the belief that aura is mostly due to anterior corneal HOAs and not PCA, and that removing the HOA just leaves ACA to treat. But there is no evidence to back that. So what astigmatism should we treat when refractive astigmatism and topo measured astigmatism disagree? Subjective RA or topo ACA? This was the subject of our published JRS study. We examined the axis of astigmatism as the single independent variable in all-comer eyes. Manifest refractive astigmatism axis was used to treat the first 900 consecutive eyes, followed by contura measured anterior corneal astigmatism axis eyes. These ACA treatments were terminated when analysis showed significantly worse outcomes. The groups were further divided into eyes with a small difference between RA and ACA access and those with a larger difference in order to analyze outcomes. The distribution of the access difference was identical in RA and ACA treated groups, and you can see that a difference of more than 45 degrees was uncommon, occurring in less than 5% of eyes. Treating on the topo-measured corneal astigmatism, the ACA, when the access difference was small, up to 20 degrees, was slightly worse, but results were similar. But look what happens when the access difference is higher, between 21 and 45 degrees. There is a significant decrease in efficacy by 5%, 15% more eyes have lower UDVA post-op, and 16% less eyes achieve 20/20. We also found that the defocus equivalent was significantly higher. 11% more eyes had residual astigmatism greater than 0.75 diopters, with a significant increased angle of error above 15 degrees. And look how telling the retreatment rates were in the large access group, 1.6% versus 11% in the ACA treated group. Note that the ACA access was used with the RA magnitude. Magnitude of error was not elevated, and so this was the correct input. Treating on ACA access and also ACA magnitude would have led to even poorer outcomes because it would not account for posterior corneal astigmatism. So the answer is scientifically clear. Treat the subjective refractive astigmatism as in all other refractive surgery LASIK platforms. We also looked at outcomes in small versus very large access discrepancy eyes above 45 degrees in 25,000 eyes. The comparison was small access discrepancy of less than 10 degrees versus very large access discrepancy of greater than 45 degrees. Percent of eyes with 20/20 was identical, the efficacy was identical, UDVA within one line of CDVA was similar. We also looked at extreme eyes with an access difference of 80 degrees or greater, showing results with exceptionally good outcomes, better than those reported in the very low discrepancy FDA study. Therefore, there should be no accuracy, efficacy, or safety reasons to exclude very large access discrepancy eyes from Contura. So why did using the manifest refraction data as treatment input lead to better refractive outcomes than using the ACA data as input? Could it be that aura is unrelated to anterior corneal HOAs and therefore HOAs do not affect the manifest refraction in primary virgin healthy eyes? To address this question, we studied the contribution of anterior corneal coma to ocular residual astigmatism and refraction in 37,000 eyes, published in JCRS. We found that the magnitude of anterior corneal coma does not correlate with that of aura or to subjective refractive astigmatism. In virgin eyes, coma is against the rule in 28%, while aura is against the rule in 86% of eyes, with no correlation between coma and aura access. Therefore, coma cannot explain the difference between subjective RA and topography-measured ACA. These findings disprove the assumptions that many surgeons still have. Another explanation for the lesser outcomes using the measured topo anterior astigmatism is that this approach ignores posterior corneal astigmatism. If aura is mostly due to PCA, treating on the ACA would neglect the PCA and lead to worse outcomes. This is exactly what we studied in this published study, showing that PCA cannot be ignored. We have shown that most with the rule eyes have less subjective CIL than corneal CIL. RA magnitude is less than ACA magnitude, while most against the rule eyes have more subjective CIL than corneal CIL, and RA magnitude is greater than ACA magnitude. The aura magnitude changes if with the rule or against the rule. What can explain this? Posterior corneal astigmatism. Studies report a range of PCA 0.3 to 0.9 diopters, with 20% of eyes with greater than a half a diopter, which is not clinically negligible. PCA has an against the rule effect in 87% of eyes. PCA reduces subjective refractive astigmatism in with the rule. PCA increases subjective refractive astigmatism in against the rule. We believe our findings are due to PCA contribution to RA. We see that the amount of HOA do not have a significant effect on aura and RA. Then why should we worry about doing contoura in eyes with elevated coma or very deep HOA ablation depth? We therefore set out to determine if treating the subjective refraction would lead to different outcomes in deep versus shallow HOA ablation depth eyes. HOA ablation depth is an indicator of the degree of irregularity on the anterior cornea since it is calculated from the amount of anterior corneal HOAs. We treated all eyes with the subjective RA as the input and not topography corneal sill. Eyes with naturally occurring irregular astigmatism or high amounts of HOAs were not excluded. The distribution of the HOA ablation depth shows how few eyes have high ablation values. 83% were less than 10 microns and only 1.8% are 15 microns or more on a 6.5 millimeter optical zone. As expected, we found a strong direct correlation between anterior corneal HOAs and HOA ablation depth. That makes sense as this is what the technology measures and treats. There was no clinically meaningful correlation between the preoperative HOA ablation depth and postoperative sphere, cylinder, and spherical equivalent. This confirms that ablation depth does not influence outcomes and accounts for less than 1% of any outcomes variation. We examined the HOA ablation depth and its effect on outcomes as the single independent variable in all-comer eyes. The third of eyes with the shallowest were compared to the third of eyes with the deepest, with an average HOA ablation depth of 5 microns in shallow group compared to 11 microns in deep group. Deep eyes had over twofold greater HOAs in coma than shallow eyes. Fewer deep HOA eyes achieved 20/20, but of note, there were fewer 20/20 pre-op eyes to start with. The efficacy was therefore identical, as was safety. UDVA within one line of CDVA was also similar. For accuracy, spherical equivalent within half and 1 diopter were identical. 3% more deep eyes has post-op cylinder of 0.75 diopters or greater, but the pre-op incidence of high cylinder was almost twice that of the shallow group, with a 30% greater pre-op cylinder magnitude average. This is what explains the higher outlier rate in the deep group. We found that the deeper the pre-op HOA ablation depth, the greater the likelihood of higher preoperative cylinder magnitude, showing a direct linear relationship seen here. Why are high cylinder eyes even more likely to get an outlier post-op? For the same angle of error post-op, which both deep and shallow groups had, a high cylinder eye will lead to a larger absolute post-op magnitude error. We also saw a slightly higher retreatment rate in the deep group, although both were below 1%, again due to the deep group's higher cell magnitude pre-op, with HOA ablation depth having no correlation to outcomes. When matching pre-op cylinder in both groups, the retreatment rate becomes the same. We looked at relative risk and found that the high cylinder eyes were almost twice as likely than deep HOA ablation depth to result in an outlier. In very deep eyes with ablation depth of 15 microns or greater, 82% achieved 20/20 and 90% were within half a diopter of plano cylinder. It's a similar outcome to the subset of eyes with cylinder of greater than 2 diopters in the FDA study. In summary, HOA ablation depth directly correlates to anterior corneal HOAs. Almost all pre-op eyes had shallow to moderate HOA ablation depth with excellent efficacy, accuracy, safety in both deep and shallow groups, and its impact on outcomes is negligible in healthy eyes. Deep HOA ablation depth directly correlates to greater pre-op cylinder. Very deep eyes showed lesser outcomes but were similar to what is seen with higher pre-op cyl. Deep and very deep HOA ablation depth eyes should not be excluded from topo-guided surgery, and we should treat them using the manifest refraction as input into contoura. We also looked at low versus high aura in a study of 21,000 consecutive eyes. The aura is against the rule oriented in 87% of eyes. In the high aura group, nearly 100% of eyes are ATR. Given that we know that PCA is ATR in 86%, we strongly believe that the main component of aura is PCA. Treating on manifest refraction encompasses the PCA in treatment as well as any other posterior sources. We described the distribution of aura, and those in the last tercile fit outside the FDA inclusion criteria. We compared outcomes in eyes with low aura average of 0.35 microns to eyes with high aura of over 1 diopter. High and low aura group efficacy was identical. So then, outcomes did not depend on the discrepancy between refractive astigmatism and anterior corneal astigmatism, or aura. This further validates that large discrepancy eyes do not need to be excluded, as was done in the FDA study. We also looked at contura outcomes in high cylinder eyes treated on subjective MR CIL above 2 diopters. Of course, eyes with naturally occurring irregular astigmatism were not excluded. The efficacy and safety indices were excellent. 97% reported improvement in quality of vision pre to post, significant improvement in severity and bothersomeness of night vision disturbances post-surgery compared to with corrected vision pre-op. The study outcomes are superior to those with high astigmatism in the literature that are non-topography guided. So treating on the manifest refractive CIL has excellent outcomes in high CIL patients, even with those with naturally occurring anterior corneal irregularities. These are the variables and the relative risk to getting an outlier outcome of greater than 0.75 diopters of CIL post-op. The total magnitude of astigmatism is most important versus access or magnitude discrepancy between RA and ACA are non-clinically meaningful. In summary, what do we treat when the RA and ACA disagree? The best outcomes are achieved using the manifest refractive astigmatism, magnitude, and access, as long as the nomogram is accurate. Treating on the subjective RA gives better outcomes than treating the topo-measured ACA. Unlike keratoconus and surgically induced irregular corneas, naturally occurring anterior corneal HOAs do not contribute significantly to RA in virgin eyes. PCA is a much greater contributor to aura and to RA than corneal HOAs and coma, and therefore needs to be taken into account when treating with topo-guided on the ACA. Otherwise, treat the RA, which incorporates it. The clinical research evidence that targeting manifest refractive astigmatism works is strong. At least 6 studies reproduced inferior astigmatism accuracy outcomes of ACA treatments compared to RA treatments. We also know targeting RA in eyes with low aura versus high aura lead to identical efficacy and accuracy, and targeting the RA in eyes with low HOA versus high HOA leads to identical outcomes as well. Here we see the fundamental research evidence that targeting manifest RA works. There is no correlation between aura and anterior corneal coma, so coma is not contributing to RA in virgin eyes. No correlation between aura and the deepest ablation depth. No correlation between preoperative aura and postoperative refractive astigmatism accuracy. No correlation between the amount of preoperative HOA and postoperative refractive astigmatism accuracy. And we see with progressively smaller optical zones, the HOA average depth becomes well below 5 microns on all eyes, which is not enough to induce a refractive effect. And of course, posterior corneal astigmatism studies report clinically meaningful PCA greater than 0.5 diopter in 20% of eyes, and therefore cannot be neglected. These are the studies treating on the RA that have reproduced the FDA findings without pre-selecting perfect symmetrical corneas. On almost 80,000 eyes, we report 92% seeing 20/20 and 65% 20/15. Our surgeon group has treated over 150,000 contura eyes with refractive astigmatism as the input, with over 50,000 eyes contributed to the current literature. The take-home message is that pre-op anterior corneal HOAs are non-clinically contributory in virgin eyes, and treating on subjective refractive astigmatism gives excellent outcomes even in eyes with deep HOA ablation profiles or with large differences between RA and ACA or AURA. There is no clinically based evidence for surgeons to seek change in methods away from the manifest protocol in healthy primary eyes. Continue treating the manifest refraction. Accurate pre-op manifest refractions and the use of calibrated and continually improved nomograms are what is actually most critical. Thank you, and please visit our research unit website.